So, if patient 1,000,001 gets sick tomorrow, no alarm bell rings in Geneva.
Right. No alarms.
Yeah, the World Health Organization doesn't have some, giant digital counter on the wall that just flips from local problem to global catastrophe the moment a specific border is crossed.
I mean, that would be convenient, but no.
Right. And I think that's the wildest part. There is actually no universally agreed upon mathematical threshold that officially turns an outbreak into a pandemic.
Which is, I mean, it completely upends how most of us think about public health because we crave hard lines in science.
Oh, absolutely. We want it black and white.
Exactly. We want the boiling point of water, the speed of light. We want our data to be precise, especially, and this is key, especially when it comes to things that can kill us.
Yeah.
But the classification of a global disease event is, well, at the end of the day, it's a judgment call made by humans looking at incredibly messy data.
And that ambiguity is exactly why we are jumping into this deep dive today. We're looking at the hidden mathematics and the really nuanced vocabulary of disease outbreaks. Because, for you listening, whether a disease is categorized as an epidemic, a pandemic, or just a localized outbreak, it triggers billions of dollars in funding.
It takes emergency powers.
Right. It shapes global policy. So our mission today is to decode all this terminology so you can turn the noise, the conflicting headlines, and frankly, the public panic into clear, rational understanding.
And to do that, we really have to look at how epidemiologists establish a baseline. You have to know what is normal before you can actually identify what's dangerous.
Okay, let's unpack this because we
Right.
hear these basic terms thrown around constantly. So let's recalibrate. We have endemic.
Yeah.
That's the baseline, right?
Yeah, endemic is the constant, predictable presence of a disease in a specific region. So, like malaria in parts of sub-Saharan Africa.
Got it. And we know a pandemic involves massive geographic spread across multiple continents, but the threshold for an epidemic is what routinely trips people up.
Oh, all the time.
Because the definition doesn't actually require, Hollywood movie numbers of sick people, does it?
Not at all. I mean, if a specific town historically expects, say, 2 cases of a rare disease per year, and suddenly they get 20 cases.
Which is still a really small number.
Right, but epidemiologically speaking, that town is in the middle of a legitimate epidemic. It's just a spike above the expected baseline.
That is wild to think about.
Well, the terminology itself reveals a lot about how our understanding of disease has shifted from storytelling to actual data science.
Okay, how so?
Well, look at Hippocrates, around 400 BCE. He coined the Greek word epidemias, which means upon the people. But he used it purely as a narrative description.
Like just describing what was happening.
Exactly. For diseases that visited a population from the outside, contrasting it with diseases that seemingly lived in the population permanently. He even tracked what we would consider the first epidemic curves, noting seasonal patterns across Greek cities, but he did it entirely in prose, like writing a story. For centuries, an epidemic was simply a story about a lot of people getting sick at once.
I love this part of medical history, the moment that narrative turned into actionable data.
Yeah.
Because you have to picture a detective mapping out a sprawling crime scene, right?
Yeah.
But the detective has absolutely no idea what the murder weapon looks like or how it operates. They just know where the bodies are falling.
And that detective is Jon Snow.
In 1854. And just to clarify for the historical record, the London physician, not the television character.
Sure, distinction, yeah.
So London is being ravaged by cholera, and the dominant medical consensus at the time is miasma theory.
Right, bad air.
Yeah, the assumption that people are dying because they're breathing in toxic, decaying air.
Yeah.
And, I mean, considering the sanitation of 19th century London, you can kind of understand why they blamed the smell.
Oh, absolutely. It was horrific.
But Snow looks at the way the disease is moving and realizes, wait, this doesn't behave like a gas. So he painstakingly maps out the cholera deaths in the Soho district, visually plotting them, street by street.
Which was revolutionary.
Completely. And he notices a massive cluster of deaths radiating outward from one specific spot, the Broad Street water pump. So he takes this spatial data to the local officials, convinces them to remove the handle from the pump so people can't drink the water, and boom, the new cases plummet.
He proved cholera was waterborne.
Exactly, without ever actually seeing the pathogen.
And the timeline of that discovery is the crucial takeaway here. I mean, Snow published his spatial statistics in 1855.
Okay.
It wasn't until nearly 30 years later, 1883, that Robert Koch isolated the cholera bacterium under a microscope.
That is incredible.
Yeah, Snow solved the riddle of transmission decades before biology could actually provide the mechanism. Epidemiology identified the pattern long before anyone knew what a bacterium actually was.
So he basically built the foundation of modern epidemiology entirely from data clusters.
He did, and by the 1920s, scientists like Kermack and McKendrick pushed that logic further. They turned historical tracking into predictive mathematics.
Right, they developed the SR model.
Yes, sorting populations into susceptible, infectious, and recovered groups, which naturally brings us to the actual numbers that govern whether a modern disease explodes into a crisis or just, fizzles out.
Okay, because at its core, contagion is basically a race, isn't it?
It is a race. Is the pathogen finding new hosts faster than the population is building immunity or changing behavior? And the primary metric for this race is R0.
The basic reproduction number.
Exactly. This represents the average number of secondary infections produced by one infected person in a population where absolutely everyone is susceptible.
So no immunity at all.
Right. And if the R0 is above 1, the cases compound exponentially. If it's below 1, the outbreak shrinks and eventually dies out.
But hold on, let me push back on this a little. Isn't R0 essentially a fixed biological barcode for a virus? Like, a specific strain of influenza inherently has an R0 of 2, regardless of the context.
It's a really common assumption, but it is fundamentally incorrect.
Really?
Yeah. R0 is a biological property interacting with an environmental reality.
Oh, interesting.
So, a virus's ability to bind to human cells dictates its potential. But human behavior, population density, climate, cultural practices, all of that dictates its actual spread.
That makes a lot of sense.
Right. A highly transmissible respiratory virus will have a vastly different R0 in a densely packed subway system in Tokyo compared to a sparsely populated farming community in Saskatchewan.
Which means the math is constantly shifting in real time.
Precisely. Because a population's behavior changes the exact moment they realize an outbreak is happening.
Right, people start washing their hands.
Washing hands, wearing masks, avoiding crowds. And that introduces a new metric, RT.
The effective real-time reproduction number.
Exactly. RT accounts for those shifting behaviors and the rising levels of immunity in the population. So when public health agencies debate whether a specific intervention, like a lockdown or a mask mandate, is working, they are obsessively tracking the RT to see if it drops below 1.
Okay, let's focus on that rising immunity part.
Yeah.
Because one of the most extreme mathematical examples we have from the sources is measles.
Oh, yeah.
The basic reproduction number for measles is just staggering. It's estimated between 12 and 18.
It's unbelievable.
One sick person can infect up to 18 others in a susceptible room.
It is quite literally one of the most contagious viruses known to humanity. And that extremely high R0 directly dictates the math of the herd immunity threshold.
Okay, let's explain that.
This is the exact proportion of a population that needs to be immune, either through vaccination or surviving a prior infection, to prevent the pathogen from finding enough susceptible hosts to sustain its spread.
And there's a calculation for this, right?
Yeah, the basic calculation is 1 minus 1 over the R0.
So, okay, for a virus with an R0 of around 2 or 3, you might only need 50 to 60% of the population to be immune to halt that exponential growth.
Correct.
But for measles, with an R0 of, say, 15, that mathematical threshold shoots up to roughly 93%.
You need an almost impenetrable wall of immunity just to break the chains of transmission.
I always conceptualize herd immunity like building a fire break in a dense forest.
That's a great way to look at it.
Right. If you clear a wide strip of trees and a forest fire hits that empty dirt, the fire doesn't instantaneously blink out of existence.
No, it doesn't.
It might still burn the brush on the edge or singe a few isolated trees, but it just cannot find the fuel to leap forward. The chain reaction is broken, and the fire eventually starves itself.
It perfectly captures the biological mechanism, because herd immunity doesn't mean the disease vanishes entirely.
Right.
Isolated cases and small self-contained clusters will still occur. But it prevents the kind of geometric explosion that collapses healthcare systems.
Yet, we do have one historical example where the fire was put out completely. Smallpox.
The great triumph.
Yeah, it remains the only human infectious disease ever entirely eradicated, officially declared gone in 1980.
1980, yeah.
But practically speaking, how did they pull that off? Because you can't just synthesize a vaccine and instantaneously inject all 4 billion people on Earth. The logistics of that are impossible.
Well, you can, and they didn't try to. The World Health Organization utilized a highly targeted strategy in the 1970s known as ring vaccination.
Ring vaccination.
Yeah. Instead of trying to carpet bomb entire countries with vaccines, public health workers focused on rigorous surveillance.
Okay.
The moment they identified a known symptomatic case of smallpox, they would rapidly trace and vaccinate every single person who had been in direct contact with that patient.
Wow.
And then they'd vaccinate everyone in contact with those people.
So they essentially built a microfire break around every individual spark before it could spread.
Exactly. It was an incredibly efficient use of limited resources. They were isolating the pathogen within a microscopic wall of herd immunity.
That is brilliant. So we understand the underlying mathematics of spread and how to calculate the threshold to stop it, but how does that transmission actually look as it plays out over months or years, and how do we accurately measure the human cost?
Well, for the timeline, epidemiologists rely on the epidemic curve, or the epi curve.
Right.
A statistician named William Farr, who was operating around the exact same time John Snow was mapping cholera, formalized what we now call Farr's law.
Okay, what is Farr's law?
He noted that epidemic diseases tend to rise and fall in a predictable bell curve shape. But, and this is important, the specific geometry of that curve reveals the pathogen's methodology.
Oh, so the shape tells you how it spreads.
Exactly. If an entire town gets sick simultaneously from a single contaminated water source, the curve is a massive, sudden spike that drops off really quickly.
Because everyone got hit at once.
Right. But if the disease is spreading person to person, the curve is much more gradual. It has a rolling peak and a very long, stubborn tail.
And those curves can also reveal some truly terrifying biological anomalies.
Definitely.
Look at the 1918 influenza pandemic.
Yeah.
And quickly setting aside the misnomer of the Spanish flu.
Right. Spain was simply neutral during World War I.
Exactly. So they weren't censoring their press reports about the sickness like everyone else was.
Right.
But anyway, this particular virus infected a third of the globe and killed roughly 50 million people.
Staggering numbers.
But the truly chilling part wasn't just the sheer number of deaths. It was the mortality curve itself. Because normal seasonal flu has a U-shaped mortality curve, right?
Yes. It is incredibly dangerous to the very young and the elderly, but healthy adults in the middle survive at very high rates, hence the U-shape.
But the 1918 virus presented a W-shaped curve.
Yeah, that W shape is infamous.
It was aggressively fatal to healthy 20 to 40-year-olds in the absolute prime of their lives.
And it remains one of the most scrutinized events in virology. The prevailing hypothesis points to a mechanism known as a cytokine storm.
A cytokine storm.
Yes. The virus didn't just evade the immune system, it provoked it into a violent, completely uncontrolled overreaction.
Meaning, if you were a healthy young adult with a robust, powerful immune system, that biological strength actually became your greatest liability.
It did. The immune response was so overwhelming that it flooded the lungs with fluid and essentially attacked the patient's own tissue.
The pathogen weaponized the body's own defenses.
Exactly. It is a really stark reminder that biological severity is heavily dependent on the host's mechanics, not just the virus. Which brings us to a critical piece of vocabulary that routinely causes massive public panic when it's misunderstood.
Oh, I know where you're going with this.
The difference between measuring cases and measuring infections.
Yes, the CFR versus the IFR. Case fatality rate versus infection fatality rate.
This distinction is absolutely vital for understanding personal risk.
Break it down for us.
Okay. The case fatality rate, the CFR, is calculated by taking the number of deaths and dividing it strictly by the number of confirmed tested cases.
Tested being the operative word.
Right. While the infection fatality rate, the IFR divides the deaths by all infections, including the mild or completely asymptomatic ones that never seek medical attention.
And therefore never get officially recorded.
Exactly.
So the CFR is inherently biased toward the most severe outcomes. If you're only testing the people who are struggling to breathe and show up at an emergency room, your denominator is tiny.
It's incredibly small.
And the resulting percentage looks apocalyptic.
Dramatically so. I mean,
Right.
think back to the initial weeks of the COVID-19 pandemic. Early CFR estimates coming out of certain regions were terrifyingly high.
I remember that. It was frightening.
But those figures lacked the broader context of the IFR. It wasn't until seroprevalence studies' widespread antibody testing were conducted months later that epidemiologists could see the true denominator.
Right. They discovered a massive layer of mild and asymptomatic infections moving through the population totally undetected.
Yeah, the virus was still deeply dangerous on a macro level, but confusing the CFR for your actual individual risk of dying if you caught the virus, that fueled intense panic.
Here's where it gets really interesting. This transition from clinical math to public perception is where the science collides with reality. Because terms like pandemic or fatality rate are not just academic theories.
No, they have huge real-world impacts.
When they're declared in real time, they become social dynamite. Categorizing a disease is a deeply complex process that fundamentally alters global policy. And looking back at how the World Health Organization has navigated this reveals how politically fraught it is.
It is a minefield.
Take the 2009 H1N1 swine flu.
Right. So in the spring of 2009, the WHO designated H1N1 a global pandemic. And mechanically, they were correct.
Because it was spreading.
The virus was spreading rapidly across multiple continents. But as the months went on, the data revealed it to be considerably milder than anticipated. It had an IFR comparable to or even lower than some severe seasonal flu strains.
Wow.
And that declaration triggered a massive political backlash. The Council of Europe and independent critics argued the WHO had unnecessarily panicked the globe.
And why was that?
Because they pointed out that the WHO's criteria for a pandemic relied almost entirely on geographic spread. It essentially ignored the severity of the illness. Plus, some critics noted financial ties between certain experts and vaccine manufacturers.
Which highlighted a massive blind spot in public understanding. A mild seasonal cold that sweeps the globe is technically a pandemic.
Technically, yes.
But a horrifying, highly lethal outbreak of Ebola contained to 3 villages is an epidemic.
Exactly. Pandemic is a geographic classification. It's not a mortality metric.
But because the public associates the word with apocalyptic severity, the WHO was accused of crying wolf.
Which heavily influenced their approach 11 years later.
With COVID-19.
Right. When COVID-19 emerged in early 2020, the WHO declared a public health emergency of international concern in January.
A PEAI.
Yes. But they notably refused to use the word pandemic until March 11th.
Which was long after the virus was entrenched in over 100 countries. They were trying to avoid a repeat of 2009, weren't they?
They explicitly cited concerns about triggering fatalism or unnecessary panic. I mean, in 2009, the epidemiological community was accused of moving too fast and overstating a threat.
And in 2020.
They were widely criticized for moving too slow, for failing to sound the alarm when containment might still have been possible. It really proves that public health isn't just about managing a virus, it is about managing human psychology.
And even when the alarm is sounded, there are fundamentally competing views on how a society should structurally respond to the threat.
Very true.
We saw this intensely debated around Sweden's approach to the COVID-19 pandemic. While most of Europe instituted rolling lockdowns to forcefully restrict movement and lower the RT, Sweden's state epidemiologist Anders Tegnell championed a drastically different model.
Yeah, Tegnell's epidemiological argument was rooted in long-term behavioral sustainability.
Meaning what, exactly?
He hypothesized that severe lockdowns merely deferred infections rather than preventing them entirely, and that forcing extreme isolation would result in behavioral fatigue, where the public simply stopped complying right when the risk was highest.
Right.
So Sweden opted for lighter voluntary restrictions. They aimed to slow the spread just enough to protect healthcare capacity while allowing the virus to move through the lower-risk population.
Theoretically, building a slow, sustainable wall of natural herd immunity over years rather than weeks.
That was the theory, yes.
The counter-argument, of course, was that allowing the virus to spread freely invited unnecessary deaths and unpredictable long-term health consequences before a vaccine could alter the math. And evaluating the actual data from Sweden's experiment remains incredibly messy. Sweden experienced noticeably higher per capita mortality than its immediate Nordic neighbors, like Norway and Finland, who implemented stricter early containment.
Right.
However, Sweden also experienced lower excess mortality than several major European nations that enacted severe, prolonged lockdowns. It really serves as this complex case study in the trade-offs between biological containment and societal endurance.
The reality is that epidemiology rarely offers flawless solutions in real time. It only offers mitigating strategies.
Yeah.
And this inherent ambiguity extends beyond just how we manage a disease to how we determine where it came from in the first place.
Oh, the origins.
Yeah, the origins of SARS-CoV-2 remain the subject of intense, unresolved debate. It's essentially split between two primary hypotheses: a natural zoonotic spillover at a wildlife market and a laboratory-associated incident in Wuhan.
And tracing that origin isn't just a matter of checking a logbook somewhere.
Not at all.
Virologically speaking, proving a zoonotic spillover requires finding the specific animal reservoir and identifying the intermediate host species that allowed the virus to jump to humans.
And proving a lab origin requires identifying the precise progenitor virus within a research facility's database.
Right. But because early environmental data collection was incomplete and viruses mutate rapidly, basically erasing their own genetic trails, the definitive mechanism remains elusive. It leaves global intelligence and scientific bodies completely divided.
And the sheer difficulty of that search brings us to the broader vocabulary we use to describe these biological intersections. The term zoonosis, a disease jumping from an animal to a human host, is just the beginning.
Right.
Epidemiologists are increasingly focusing on the concept of a syndemic.
Now, a syndemic goes beyond just two viruses circulating at the same time, doesn't it?
Much further, yeah. It describes how a biological pathogen physically interacts with sociological factors to amplify the damage.
Give me an example of that.
Okay, so if a virus enters a community suffering from intense systemic inequality, that population is already dealing with chronic stress, which elevates cortisol levels and directly suppresses immune function.
Wow.
Combine that with, say, food deserts leading to high rates of diabetes, and the virus isn't just spreading, it is biologically synergizing with poverty to create a much higher fatality rate than the virus could ever achieve on its own.
So you cannot isolate the biology from the society it infects.
You really can't. And that sociological layer is further complicated by what public health officials now call the infodemic.
The infodemic.
Yeah. The WHO formalized this term to describe the rapid parallel spread of misinformation alongside the actual biological virus.
Right, because if a false rumor about a vaccine or a fake cure goes viral, it immediately alters human behavior.
And that, in turn, alters the RT of the pathogen. Managing the information environment is now biologically necessary to manage the disease itself.
Which brings us perfectly back to our core mission today. Why does understanding the difference between CFR and IFR, or grasping the math of herd immunity, why does it actually matter to you?
It matters deeply.
It matters because this vocabulary acts as a series of legal and social triggers. These definitions dictate border closures, economic mandates, and your own personal risk assessments. If you don't understand the mechanisms behind the headlines, you are vulnerable to the infodemic.
Absolutely.
Grasping these concepts empowers you to critically evaluate the policies your leaders enact and the risks you actually face, rather than just reacting blindly to shifting data.
And looking ahead, that data is only going to get more complex. We discussed earlier how humanity managed to completely eradicate smallpox using ring vaccination.
Right, the micro fire breaks.
Exactly. But that strategy relied entirely on one crucial factor. Smallpox produced highly visible, unmistakable symptoms. We knew exactly who was sick, so we knew exactly where to build the fire break. But considering the massive gap we discussed today between case fatality and infection fatality rates, what happens when the next pandemic is caused by a highly contagious virus where 90% of the infections are completely, entirely asymptomatic?
Oh, wow. If you can't see the fire, you don't know where to build the fire break.
Exactly. Can humanity ever truly eradicate a disease using traditional epidemiology if the vast majority of the pathogen's footprint is invisible?
Jon Snow managed to track a killer by looking at the footprint it left behind. But tracking a pathogen where the vast majority of cases leave no visible footprint at all, that is an entirely different kind of mystery. The mathematics of epidemiology are elegantly precise on paper, but as we've seen today, applying them to the chaotic reality of human behavior is always a judgment call. Keep looking closely at the data, keep questioning mechanisms behind the headlines, and we will see you on the next deep dive.